All right, well, those are some tough acts to follow, but here goes. I'm Bill Liu. I'm one of the radiation oncologists here at Stanford, focused on lung cancer. And what I'd like to talk about today is the C word. And of course, cancer is the C word that many patients dread to hear in the doctor's office. Many doctors are still uncomfortable talking about it. But the C word that I want to focus on is, as a cancer doctor, we've been conditioned over the years to be perhaps a little bit hesitant to discuss the first word on the slide here, which is cure. And perhaps that's because, as you've heard before, we've underappreciated the complexity of cancer, the difficulty of it, and we've perhaps overpromised in the past. But all the exciting advances that you've heard about are giving us new hope. Now, cure is not a word that we've historically associated with difficult cancers like lung cancer. This is a patient of mine, and you can see that at the time of presentation, this patient had an advanced lung cancer, a large tumor in the left lung with lymph node involvement, and a metastasis to the adrenal gland. So this is stage 4 incurable lung cancer. And yet, if we don't attempt to address cure as the goal for a lot of our patients, then we may be shortchanging some of them. This is the same patient 10 years later with no evidence of cancer, cured of incurable lung cancer. And you might ask, well, how did that happen? Was it a new immunotherapy? Well, that wasn't available at the time this patient was treated. This patient was treated with radiation therapy combined with chemotherapy and cured. And in fact, the story goes on, 15 years out from the initial treatment now, he's been cured of a second separate lung cancer with radiation therapy. So radiation therapy is one of the key pillars of treatment of cancer. It's used as part of curative intent treatment for the most patients of any treatment modality. So that's something that I think not a lot of people realize. And so you might ask the question, so what does it take to cure cancer? So I'm a simple-minded guy, and so to break it down as simply as possible, I think you've heard it from Dr. Artandi earlier, every cancer therapy is all about balancing tumor killing versus collateral damage to normal organs. In fact, cancer can only be cured if the treatment needed to eliminate the cancer is tolerable to the patient. We can also flip that around and say that if the treatment needed to eliminate the cancer is not tolerable, that is a definition of incurable cancer. And with conventional therapies, conventional radiation, other treatments, whether it's surgery, whether it's chemotherapy, CAR T-cell therapy, all of the same principles apply. Collateral damage is often what limits our ability to cure. So what I'd like to talk about now is a new development in radiation therapy, and hence the title Lightning Speed. Ultra-rapid radiation therapy is emerging as a way to change that balance between tumor killing and collateral damage, hopefully in a way that will be game-changing. So where my journey began in this is as a cancer doctor working in the clinic, working together with my collaborators like Peter Maxim, pictured here, a medical physicist. We have spent years implementing new technologies in the clinic to make radiation therapy more precise, more accurate, more image-guided, more personalized, exquisitely sculpting radiation dose to concentrate on tumors and less on normal organs, so to achieve that balance of collateral damage and tumor killing. But one of the final challenges that we face in ultimate precision is the fact that our bodies move. So every part of the body moves all the time, and so we're constantly shooting at moving targets when we're trying to treat these tumors. And so we've developed these complex compensation techniques, synchronizing radiation with breathing, chasing the tumor with radiation beams, all because of the assumption that it takes longer to give the radiation treatment than for the body to move. So we asked the question, what if we could flip that around? What if radiation could be so fast to be almost instantaneous, then all of that motion would be frozen, we'd have the most precise therapy. So as we were thinking about strategies to achieve this technologically, we also started asking the question, could there be new biological effects of ultra-rapid radiation? And the surprising finding that we've discovered in our labs and leading labs around the world, this is work by my colleague Aaron Rankin, who's pictured here. If you give whole abdominal radiation to a mouse, the sensitive organs, the intestine there, you give a large dose of radiation, that's lethal to the mice. All of them die within about 10 days from diarrhea. If you give the same dose of radiation to the whole abdomen, but ultra fast in a fraction of a second, that lethal dose of radiation, actually almost all of the mice survive. And you look at the tissue of the intestine, what we find is that a few days after the radiation, in those mice that got the flash radiation, there's much higher regeneration of the intestinal crypts, the stem cell compartment of the intestines, than with the conventional radiation. On the other hand, when we look at the control of ovarian tumors in the abdomen, we find that the same dose of flash and conventional radiation produce equal amounts of tumor killing. So tumor killing with less collateral damage is certainly a holy grail of cancer therapy. This is something we've observed in preclinical models in mice, besides the intestines, in the brain, cognitive function, lungs, skin, sparing of normal tissues with flash. In zebrafish, in cats, and many pigs, it's been observed in a lot of models. But to translate this to humans, which is really kind of the exciting idea, it turns out that the technologies that we have to do these sorts of ultra-fast treatments in mice don't scale up to humans, where you have to treat deep-seated, large volume tumors. You need something completely new in terms of technology. And so the heart of our treatment machines in radiation therapy is the linear accelerator, and the microwave-powered electron linear accelerator was invented here in the 1940s by Hansen at Stanford. But for the last 6 decades or so, the basic design hasn't changed very much. At the time we were looking into these new concepts, my colleague at SLAC National Accelerator Lab, Sami Tantawi, had made a new breakthrough with a new class of linear accelerator designed with much better power efficiency, enabling much more beam generation compared to our conventional clinical machines, and also more compact. You can see that's Sami there, and how small this device is that could replace the accelerator within a clinical treatment machine. Also pictured here is SLAC National Accelerator Lab. That's the SLAC 2-mile-long accelerator, which you can see from an aerial view going under Highway 280 there. And using that as a measuring stick, you can see that it's about 2 miles from the Stanford campus and Stanford Cancer Institute, highlighting the kinds of unique collaborations that we're able to have here at Stanford, unlike just about anywhere in the world. So this is what we think it will look like. This is actually the current state of the art, the fastest radiation treatment in the world that we can do today. You see the radiation machine aiming a beam at the tumor in the patient. It's a lung tumor. You can see it's moving around, so all these different beam directions focus on where the tumor is. A highly focused ablative dose of radiation. You can see the machine is synchronized to the patient's breathing. It'll take about 3 minutes to deliver this full treatment, which is longer than the time I have left in this talk. But if you look at the vision of what we want to do, now don't blink. That's it, it's done. The same highly focused ablative dose of radiation delivered in a fraction of a second, 400 times faster than we can currently do it today, to give the ultimate precision, exploiting the benefits of flash radiobiology, and importantly, designed to be very compact and economical. And the reason that's important, you've heard already, cancer is the #1 killer in the world. At the 1-year anniversary of the COVID pandemic, about 2 million deaths from COVID. In the same period of time, 10 million deaths from cancer around the world. And most of those are occurring in the developing world. And in fact, as of today, only about half of patients worldwide who could benefit from radiation have access at all. What that means is that millions of patients who should be able to receive curative treatment only get palliative treatment today. So this is an ongoing, immediate health crisis worldwide. So how can we address that? Our vision is to design this phaser technology to be economical and compact enough to fit within a standard cargo shipping container, And that's a form factor, actually, that's been used in other settings. For example, to package solar power and battery storage for emergency power deployed anywhere around the world in kind of emergency zones. Compact operating rooms have been designed to unfold from this same sort of cargo shipping container. So if you imagine a surgical operating suite, power, chemotherapy infusion, CT scanning, all that could fit within boxes, and the missing element, radiation therapy, we could deploy an entire cancer center, state-of-the-art, anywhere around the world in 6 boxes. So just to come back to kind of a historical note, our chair of radiology, Sam Gambier, who unfortunately we recently lost to cancer, had a motto, invented at Stanford, used everywhere. And certainly that has been the story of radiation therapy. The first klystron-powered medical linear accelerator was invented here at Stanford by Kaplan and Ginston. First patient treated in 1956, shown here. That young boy was cured and still alive today. The John Adler, our neurosurgeon, who invented the CyberKnife, the first image-guided robotic radiosurgery system. And we certainly hope very soon phaser, invented at Stanford and deployed here. So I'd just like to conclude by thanking an outstanding multidisciplinary team of people, many of them who aren't even pictured here, for their great work in making all of this happen and their dedication to set phaser to cure. So I'd like to thank them and thank you for your attention.